Let's first look at drug strategies for the treatment of hypertension. You basically have three targets for our drugs to lower blood pressure. You can reduce TPR, which means you can target blood vessels. You can reduce cardiac output, which means you can target the heart. Or you can reduce body fluid volume, which means you can target the kidneys. And kind of a simple way to think about today's algorithms for treating hypertension is you pick one of these three targets. And most often, patients are going to need a second drug. And so your second drug should go after one of the two remaining targets. For example, if you start with a drug that reduces TPR, the body may actually compensate. It may cause a homeostatic compensatory effect that could perhaps lead to a reflex tachycardia or edema. So a second drug that you might add to that patient could be a beta blocker to offset the tachycardia, or it could be a diuretic to offset the edema. Remember, many patients with hypertension are going to need combinations of drugs. In the margin is a clinical correlate about the most popular drugs for hypertension today. The current recommendations say use a thiazide diuretic, an ACE inhibitor, or a long-acting calcium channel blocker as first-line therapy because they're all considered equally effective. So once again, select one of those drugs, and if the patient needs a second medication, you often will go with one of the remaining options. Thiazide diuretics were covered in detail in the last chapter. They're very popular in the management of hypertension, but again, we've already covered their properties, so see the diuretics chapter. Let's take some time and look at the angiotensin system. This is a diagram that you should be already very familiar with from physiology. However, I want you to look at this picture kind of through the eyes of the drugs, if you will. Where do the drugs work, and what specifically are they going to cause as effects? So when we look at this pathway, and it starts with angiotensinogen, angiotensinogen is converted to angiotensin 1 by the actions of renin. So the drug called aliskiren is a direct renin inhibitor. So as you know the action of that drug, you know that it specifically blocks renin. That's never going to be the test question, right? The question will never say which drug below blocks renin. That's just way too easy. What they might say is, when a patient with hypertension is started on aliskiren, which of the following is going to accumulate as a result of the action of this drug? So always know what's going on either side of the pathway. Renin converts angiotensinogen into angiotensin 1. So the actions of aliskiren result in the accumulation of angiotensinogen. And it also results in the immediate inhibition of the formation of angiotensin 1. If you keep going, we know that angiotensin 1 is converted to angiotensin 2 by the enzyme called ACE. And that's the target for ACE inhibitors. So the actions of those drugs are going to result in the accumulation of angiotensin 1 and inhibit the formation of angiotensin 2. So hopefully you see how I'm asking you to look at this picture. But what else does an ACE inhibitor do? You're really asking, what does the ACE enzyme do? Besides converting angiotensin 1 to angiotensin 2, this enzyme inactivates bradykinin, and that's very important because an ACE inhibitor will cause the accumulation of bradykinin. And still today, one of the most popular test questions is about a side effect for ACE inhibitors, and that is cough, a dry, nagging cough. They may ask you about the side effect. They may ask you about the cause of the cough. And the current theories are that bradykinin is contributing to the cough. Elevated levels of bradykinin seems to have some effect on pulmonary afferents associated with the cough reflex. So more bradykinin can lead to this dry, nagging cough. If you go further down the pathway, once you've formed angiotensin 2, angiotensin 2 binds to its receptors, which are called AT1 receptors. By the way, AT1 stands for angiotensin 2 type 1 receptors. And those receptors are found on blood vessels, where they cause vasoconstriction, and they're found in the adrenal cortex, where they cause aldosterone secretion when stimulated. So the group of drugs known as ARBs, angiotensin 2 receptor blockers like losartan, block these receptors. Block the binding of angiotensin 2 in your blood vessels and the adrenal cortex. Notice that ARBs work downstream of the ACE enzyme. So ARBs don't have any influence on bradykinin metabolism. Bradykinin is metabolized just fine in the presence of an ARB. So since those drugs don't elevate bradykinin levels, they're not associated with a cough. And there's our second most popular test question. If a patient is started on an ACE inhibitor and they get the cough, and you want to switch them to a drug that can have the same benefit but without the cough, well, that's an ARB question. Hopefully you get that on your test. But the third possibility for a test question always makes folks a little nervous. Yep, it's that up-down arrow question. They want to know what's going up and what's going down based on the action of drugs that work in this pathway. Let's look for some things that all three types of drugs have in common. They're all going to disrupt the whole renin-angiotensin-aldosterone pathway. So the net effect of aliskiren, an ACE inhibitor, or an ARB is to block the action of angiotensin II, therefore you get vasodilation. TPR goes down and blood pressure goes down. All three types of drugs, by inhibiting the action of angiotensin II, are going to decrease aldosterone secretion. So now instead of sodium and water retention, I get sodium and water loss. I get a diuretic-like effect, and that can lower blood pressure. But let's look at one thing specifically, physiologically, that happens in this diagram. The actions of angiotensin II normally will increase aldosterone secretion and cause sodium and water retention. Well, when the body has enough sodium and water, you get a negative feedback on renin. In other words, I don't need renin-angiotensin-aldosterone activity if I have sufficient sodium and water. So there is a negative feedback system. What do the drugs that inhibit this pathway do? By inhibiting this pathway and decreasing aldosterone, these drugs are going to cause sodium and water loss. And what does that do to the negative feedback on renin? It disappears. My negative feedback is now gone, so the levels of renin go up. This is a very popular question about an ACE inhibitor or an ARB. Both types of drugs are going to specifically raise renin levels because of loss of this feedback mechanism. So that's the way you want to look at the picture. You understand the diagram, the normal physiology of what's going on with this pathway. Plug the drugs in, know exactly where they work, but think about that up-down arrow question. What is changing as a way to distinguish them? I will tell you that the keys in that type of question, the levels of angiotensin I, angiotensin II, and bradykinin, are all going to be important factors to distinguish the type of drug. When you think about ACE inhibitors, they're prils. If we look at the ending of the drug's name, captopril, lisinopril, and all of the other prils, it's one of the nice things about many of our cardiovascular drugs, that they have common endings or parts of their name that make them easier to identify. As we've said, these drugs are going to block the formation of angiotensin II, preventing the stimulation of angiotensin II receptors. They decrease aldosterone, they cause vasodilation, and obviously they're going to raise the levels of bradykinin. ARBs are sartans, losartan and all of the other sartans. So look for the common ending. It doesn't matter which drug they choose out of this family, you can identify it as a drug that blocks those AT1 receptors on blood vessels and in the adrenal cortex. Same effect as ACE inhibitors on the blood pressure mechanisms, but no effect on bradykinin metabolism. The newest of all of the agents that affect the renin-angiotensin-aldosterone system is the direct renin inhibitor aliskiren. As we saw in the diagram, it blocks the formation of angiotensin I. Similar to ACEs and ARBs, you're going to lower blood pressure because you're decreasing TPR and also because of sodium and water loss. Aliskiren does not directly interfere with bradykinin degradation. ACEs and ARBs are very popular drugs in mild to moderate hypertension. Almost always, you choose the ACE inhibitor over the ARB. That's just simply a matter of those drugs have been around longer, they cost less, there's more literature out there on an ACE inhibitor, but they're both considered equally effective, so very good for hypertension. They're also useful in diabetics because they can protect against diabetic nephropathy. We'll explore this more on a later slide. We'll also see that these drugs are very, very popular in heart failure patients. There's a note on page 91, a clinical correlate, that tells us that patients greater than age 18 with chronic kidney disease and hypertension should receive an ACE inhibitor or ARB to improve kidney outcomes. So basically, whether it's a diabetic or an individual with chronic kidney disease, ACEs and ARBs are renal protective and are very, very important drugs. The most common side effect of an ACE inhibitor is that dry, nagging cough. I don't want folks to misunderstand that. You would never think about, well, I won't give this person an ACE inhibitor because it causes cough. Certainly you would give that person an ACE inhibitor, and only if they complained of the cough to the point where they wanted to discontinue would I then look to switch them to an ARB. So don't ever be thinking, well, I'll automatically put them on an ARB and skip the ACE inhibitor. Even though the cough is common, most people who get it don't even have to discontinue the medication. So it's annoying, but not always a reason why you should skip that group of drugs. What about hyperkalemia as a side effect? Does this make sense? ACEs and ARBs stop the production of aldosterone, and aldosterone is potassium wasting. So drugs that inhibit aldosterone, as we saw in the previous chapter on diuretics, can cause hyperkalemia. Here's kind of a paradoxical statement, because on my previous slide, I talked about how ACEs and ARBs protect your kidneys. This slide tells us ACEs and ARBs can destroy your kidneys. They might cause acute renal failure, and this happens in patients with bilateral renal artery stenosis. So it's a very specific situation. And again, I'll discuss the kidney on my next slide. Angioedema is a more serious side effect. It's just not very common. Angioedema. The patient is going to experience a rapid swelling in the facial region. The lips, the tongue, are going to swell up typically right after the first dose of an ACE inhibitor. We believe that bradykinin may also play a role in causing angioedema. So ACE inhibitors are much more likely to do this compared to ARBs. Whereas the cough occurs in about 20% of patients, angioedema occurs in about 0.1% of patients. So it's more rare, but it's more serious. You discontinue the medication. You treat the patient symptomatically. Antihistamines are sometimes used in this setting as well, but you avoid further use of the ACE inhibitor. These drugs are contraindicated in pregnancy. They're actually category D, which means they're known teratogens. They can cause a number of defects in the fetus. Renal, cardiovascular defects are among the list of things that they might do to the fetus. So definitely, if you have a patient who's pregnant, immediately discontinue these drugs, because there really isn't a situation where you would try to continue these medications in pregnancy. I've drawn a diagram here that maybe you can add to your margin of the book. It's a diagram to look at why we're using ACEs and ARBs for their renal protective effects, but it can also give us an opportunity to explain why these drugs in certain situations might also cause renal failure. You know, the cartoon that I've drawn here is kind of an illustration of the way that I would hope that you are drawing things, which means you're not spending a lot of time being a perfect artist. You can tell that my Pac-Man here, which represents the glomerulus, I didn't spend a lot of time trying to come up with a perfect diagram. I just wanted to simply depict the afferent arteriole coming into the glomerulus and the efferent arteriole leaving, and then show you and remind you really that prostaglandins dilate the afferent arteriole, whereas angiotensin II constricts the efferent arteriole. When prostaglandins are dilating the afferent and angiotensin II is constricting the efferent, I'm going to get maximal filtration pressure. I'm going to get my maximal GFR in that normal physiologic setting. So first things first, ACEs and ARBs are going to stop angiotensin II, which means they're going to dilate the efferent arteriole. Dilating the efferent arteriole is going to reduce filtration pressure. It's going to slightly reduce GFR. Now, what is the benefit of that action on diabetics? Well, certainly there's two things here. One, those drugs are great at controlling the blood pressure of your diabetic. And number 2, by decreasing the work of the kidney, you're less likely to get proteinuria. So there's the benefit. The renal protective effect is these drugs are reducing the work of the kidney. You're less likely to spill protein. But why is it that they might cause acute renal failure? In other words, when is dilating the efferent arteriole a bad idea? Remember, if you have a patient with bilateral renal artery stenosis, now they've got reduced blood flow coming into the kidney. So if you've got a constriction on the afferent side, the one primary thing that is maintaining GFR is the efferent arteriole being constricted. If I dilate the efferent arteriole in the face of renal artery stenosis, I can cause renal failure. I can further reduce GFR. So that's something that you want to avoid in situations where you have low renal function already, low GFR. Watch out for ACEs and ARBs. They can exacerbate and cause renal failure. What's the role of NSAIDs in this picture? Since NSAIDs inhibit prostaglandin production, that means NSAIDs, especially high doses and chronically, can lead to constriction of the afferent arteriole, and that can cause renal failure. That's one of the properties of NSAIDs we'll discuss in a later section, that high doses for long periods of time can lead to chronic renal problems, including renal failure. Our next group of antihypertensives are calcium channel blockers. These are drugs that block the L-type calcium channel in the heart and in blood vessels. By decreasing intracellular calcium, they can certainly lead to a vasodilating effect, or they can lead to a reduction in cardiac output, and that can certainly be beneficial at lowering your blood pressure. We're going to look at all of the different calcium channel blockers and describe exactly whether they're more likely to work on cardiac or vascular calcium channels. When we look at the individual calcium channel blockers, there are verapamil, diltiazem, and the dapines. The prototype of the dapines is the drug nifedipine. Again, notice the ending. That is a family name for our calcium channel blockers. And collectively, these are known as dihydropyridines. Sometimes in a test question, you will see the term dihydropyridine calcium channel blocker, but you might also see non-dihydropyridine calcium channel blocker, which means you're talking about verapamil or diltiazem. If you look at this figure in your book, I think this figure, which is very, very simple, by the way, does a great job of having you think about the calcium channel blockers. Notice the heart is on the left and the blood vessels on the right. When I look at my calcium channel blockers, there's verapamil, diltiazem, and the dapines. If I put them in the order that I see here, maybe you can remember the VD dapines. VD dapines is a way to think about the action of these drugs. In other words, which type of calcium channel blocker is the most vascular selective? Well, that would be the dapines. On the other hand, which calcium channel blockers are the most cardiodepressant? Well, diltiazem, but definitely verapamil. What about being able to answer some side effect questions just by looking at this diagram? I think you can do this. Which calcium channel blocker is the most likely to cause symptoms of congestive heart failure? Well, that would be the one that's the most cardiodepressant. That would be verapamil. On the other hand, which type of calcium channel blocker is most likely to increase the heart rate? Wouldn't that be the dapines? They're vasodilators. Decreasing TPR and blood pressure could cause reflex tachycardia. So thinking about the properties and thinking about possible side effect potential, that's what this figure does very nicely for you. It turns out that all calcium channel blockers are useful for hypertension. Whether they're more cardioselective or vascular selective, either of those options are beneficial. All calcium channel blockers can be used in angina. When we get to that chapter, we'll talk about why certain calcium channel blockers might be slightly better for one type of angina compared to another. What about arrhythmias? I want you to notice that for arrhythmias, we only use verapamil and diltiazem. Does that make sense? We want the two that are more cardioselective. Because slowing down the heart rate, that's our antiarrhythmic mechanism. Why do you stay away from dipines as antiarrhythmics? Because they can cause reflex tachycardia. Not beneficial. There's your side effect profile. Dipines and reflex tachy. We've already discussed that. But what about gingival hyperplasia? If I say the term gingival hyperplasia, I bet one drug comes to mind. What's that drug? Phenytoin. Another drug that can cause gingival hyperplasia? Cyclosporin. The immunosuppressant drug cyclosporin can cause gingival hyperplasia. And here, I remind you that the dipine calcium channel blockers can do this as well. It's another one of those things. I rarely think you're going to have somebody walk into your office and say, "Hey doc, I think I've got gingival hyperplasia." Look for the description of red, thick, swollen gums. Gums that grow down over the teeth, or perhaps bleeding gums, as an indication of gingival hyperplasia. And remember, that could happen with certain calcium channel blockers. The final side effect, constipation, especially with verapamil. You've got to watch out for this. I would say that if you think about constipation as a side effect that might show up on test day, the first group of drugs that you have to think about for constipation is opioids. Opioids are very constipating. Maybe a second group of drugs you think about causing constipation, muscarinic antagonists. Muscarinic blockers like atropine cause constipation. And then there's the drug verapamil. So this side effect is sometimes tested on the exam, and so make sure you're aware of that. The next group of drugs we're going to look at are beta blockers. We've discussed a lot of the properties of this group of drugs back in our autonomic nervous system section. So when you think about mechanisms, go back to that chapter and review. But we're going to cover some other properties, including side effects of these drugs, on the next slide. Obviously, beta blockers are going to cause cardiovascular depression. And because most of them get into the CNS, they can cause fatigue. Remember that atenolol is an exception because atenolol doesn't have the sedative effects. It doesn't get into the CNS. These drugs can cause sexual dysfunction, and this can be a reason for patients to discontinue the medication. Also note, they can increase LDLs and triglycerides. Like thiazide diuretics, they can raise your lipids, and so they're not good choices in patients with pre-existing hyperlipidemia. You also never want to abruptly discontinue your beta blocker. If you do, abrupt discontinuation can lead to a pretty significant rebound effect on the heart, including rebound hypertension. With regards to cautions for beta blockers, asthma, vasospasm, and diabetes, most often you're thinking about these are reasons to avoid non-selective beta blockers. That's why most commonly you're going to use beta-1 selective drugs like atenolol or metoprolol for your treatment of hypertension. You avoid the issues with asthmatics, folks with vasospasm, or diabetics. But let's explore the idea of what's happening in a diabetic a little further. Notice that all beta blockers are going to at least block beta-1 receptors. And because you're blocking beta-1s, you might mask the tachycardia due to hypoglycemia. Perhaps a way to think about it is this. How does a person know that they're hypoglycemic? What are some of the symptoms that they experience? You might think about confusion or sweating or perhaps palpitations. What I'm telling you is that if you're on a beta blocker, if palpitations was one of your warning signs, you're going to not get that symptom while you're on the beta blocker. So it masks the tachycardia. In other words, if that was your trigger, that's how you knew your blood glucose was low. Your blood glucose can continue to drop because you're not sensing the tachycardia. So be careful with a beta blocker, especially in diabetics. We have drugs that block alpha-1 receptors. We've also discussed these drugs earlier, way back in our autonomic nervous system chapter. They're going to vasodilate on both arterioles and veins. So a decrease in both arteriolar and venous resistance. That's why I call them non-selective on the vasculature. Most vasodilators, in fact, dilate arterioles and veins. and that's what we see for our alpha-1 blockers. Reflex tachycardia is a possible side effect. Again, that should make sense. Vasodilating and dropping the pressure can cause reflex tachycardia. The common ending for these drugs, Zosyn. So whether it's prazosin, doxazosin, or terazosin, Zosyn is the common ending that you're looking for. There are two important uses for these drugs, hypertension and BPH, and chances are very good that the time that you're going to use these drugs on exam day is when you have a patient with both conditions. The comorbidity drives your choice of what's the best drug in hypertension. So many times it's not just a hypertension question. It's hypertension and a second condition. If that is BPH, pick one of the Zosyns. They're the most effective drugs in that situation.